introduce Walid, please, for the next speaker?
Yes. Where is it? Walid. Where is Walid?
Okay, no question. Thank you very much. We shift now to the second speaker.
Yes.
Dr. Professor Walid Abdel Ghany from Egypt. He is professor in neurosurgery at Ain Shams University. Can we start, Dr. Abdel Ghany?
Thank you.
John?
Thank you for inviting me for this excellent and well-organized meeting. I am Walid Abdel Ghany from Egypt. I'm a professor of neurosurgery and the director of Movement Disorder Clinic at Ain Shams University. My talk today will be about the central and peripheral ablative procedures for hypertonia, especially in pediatric age group. I have no disclosures. My objectives today is to justify and clarify the role of neurosurgical ablative procedures in the management of hypertonias regarding the indications, techniques, and the outcome. When we estimate the role of functional neurosurgery for functional disorders, we find that neurosurgery for hypertonia is underestimated. This graph shows the National American database regarding the functional disorders, including chronic pain syndromes, Parkinson's disease, epilepsy, in comparison to the other movement disorders associated with cerebral palsy, spinal cord injury, stroke, MS, and the neurodegenerative disorders. We find that the procedures for the movement disorders, especially the hypertonia, is much less estimated, despite of being very effective. Let's see this video for ambulatory cerebral palsy girl. This pattern is what we can see in a growing child with cerebral palsy. We have two extremes, either functioning ambulatory or, on the other hand, the non-ambulatory. We can estimate the impact of hypertonia on both sides. In the left side, the girl grow with miserable malalignment and many rotational deformities in lower limbs. In the picture in the right side, for a boy with severe disability affecting the whole of the body, and the impact of hypertonia resulted in this severe form of joint and muscle shortening and deformity, if kept untreated. As a neurosurgeons and functional neurosurgeons, we know that there is many pathology either in the brain or spinal cord affecting the development and prognosis of hypertonia. In this kid with a generalized form of hypertonia, we can see the impact of spasticity and dystonia. If present together, it will be mixed hypertonia. And this hypertonia in the presence of musculoskeletal changes associated with the upper motor neuron lesions are resulted in a force called the torque. The torque is the sum of forces which imposed on the growing skeleton, either by the hypertonia or by the local changes in the muscle and skeleton. This force may result in deformity in the axial skeleton, resulting in scoliosis or pelvic obliquity, or in the peripheral skeleton, resulted in rotational deformities and joint dislocation. In 2013, an Australian group made this magnificent systematic review regarding the interventions for children with cerebral palsy, and they addressed the state of evidence. In about 164 publications, included about 64 procedures for management of cerebral palsy disability. They concluded and gave light traffic colors for those procedures with high evidence, We have the green color for the procedures which is mostly effective and should be done for almost all people with or children with cerebral palsy. First of them was the tone controlling procedures like botulinum toxin, RHIZOTOMY, or some medications for lowering. Others like casting, hip surgery, some physical therapy techniques, and bisphosphonates to improve bone density, and to care about the pressure sores and ulcers, and the anticonvulsants to control seizure, which is an indirect cause for deterioration of motor function in children with cerebral palsy. Most of procedures had a moderate or low level of evidence, and we should think before applying it to children with cerebral palsy spasticity, like baclofen or intrathecal baclofen, or some orthopedic techniques like hand surgery, or some procedures like the single event multi-level soft tissue lengthening, and many others techniques. And about 6% of these procedures have no rule or have not yet estimated as a useful procedures for management of hypertonia or spasticity hypertonia, like the craniosacral therapy, hip bracing, hyperbaric oxygen, neurodevelopmental training, and sensory integration. Actually, in cerebral, in hypertonia, we are managing the sequelae or consequences of the upper motor neuron lesion. We have, among the literature, we have studied the upper motor neuron lesion consequences in two patterns: either the vertical pattern, it means that upper motor neuron lesion resulted in spasticity, which in turn resulted in muscle stiffness, and this muscle stiffness lead to bone deformity and joint deformity. Actually, this is not the real situation. The real situation is we have all the procedures running at the same time. When we have an upper motor neuron lesion, spasticity started, muscle stiffness is going on, and deformity started. So we have to treat from the day zero. We don't have to wait until muscle stiffness and bone deformity occurs. In cerebral palsy hypertonia, we have studied the progress and the development of the gross motor function among the children and youth with cerebral palsy. We found that according to the gross motor function classification for cerebral palsy function, those kids with motor function or growth motor function level 1 and 2 usually developed and gain the ambulatory function by the age of 5, and they can sustain this function among the years later on. But those with gross motor function 3, 4, and 5 are liable for regression and deterioration of their motor abilities by time due to growth and the impact of deformity on the ambulatory level. So we have to introduce our management as early as we can. The timing of interventions in cerebral palsy hypertonia is determined by mostly by the age. We can find that in early years of life, we mostly can apply the tone management procedures, like either medications like botulinum toxin injections or neurosurgical ablative procedures. And by time, we find that the inevitable changes that happened in the tendons and muscles and bone make the orthopedic intervention mandatory, either alone or in conjoined with the neurosurgical procedures at the same time. Neurosurgery, we have an armamentarium of techniques started with simple procedures like the physical therapy, botulinum toxin injection, simple tendon lengthening. In more severe cases, we can apply the neuroablative procedures like combined rhizotomy, the selective dorsal rhizotomy, selective peripheral neurotomy, DREZOTOMY, median myelotomy, and some orthopedic techniques like tendon transfer and advanced physical therapy techniques. And recently, we have an elegant neuromodulation techniques which can help much for motor development, like the intrathecal baclofen, deep brain stimulation, and spinal cord stimulation, and some corrective osteotomies and the orthopedic surgery to correct the lever arm dysfunction, and the high technology physical therapy techniques like the robotic rehabilitation. Regarding the DREZOTOMY and MYELOTOMY, both have good impact on reducing muscle tone, beside its role in controlling severe chronic pain syndromes. It's indicated in painful paraplegias, hemiplegias, and as we know that DREZOTOMY for cerebral palsy was introduced in 1976 by Marc Sindou in Lyon, France. This graph, we can show the site where we can do the myelotomy. It's done in the central sulcus in the spinal cord up to the central canal to disconnect the crossing fibers between the both sides and decrease the hypertonia in both lower limbs. Regarding the DREZOTOMY or dorsal root entry zone ablation, it's done in this area by many techniques, either the radio frequency or microsurgical techniques or laser techniques in some institutions. And we introduce the lesioning probe in 45 degrees to the midline to 1 or 2 or 3 millimeters in depth. And we interrupt the cells or myotatic fibers in the dorsal root, dorsal horn, and dorsal root entry zone. In 1932, Sir Charles Scott and Edgar Douglas have their Nobel Prize regarding their discoveries in the functions of neurons. Actually, they discovered the pathway for tone control and the rule of how could the spasticity developed in their work on the cerebrated cats, where they cut the dorsal roots and find that it results in hypotonia after decerebration or spinal cord injury in cats. Actually, this man was the real introducer of our procedures, which is called the dorsal rhizotomy. In 2016, we in CHAMPS published this technique regarding the combination of the anterior and posterior lumbar rhizotomy for treatment of mixed dystonia and spasticity in children with cerebral palsy, as we found that not all children with mixed hypertonias got benefit from sectioning of the dorsal root only. So we have to combine the anterior and posterior root resections selectively, and based on quantitative and qualitative measurements to control both arms of the reflex arc, especially in dystonia. When we revise the pathways for controlling the motor function in the brain, spinal cord, we find that spasticity is a monosynaptic stretch reflex arc, which is easily identifiable and easily targeted, while dystonia, as we can see, this very sophisticated control interactions and controls between neurons make the management of dystonia is somewhat difficult and maybe disappointing in some circumstances. It's important to differentiate between type of hypertonia in cerebral palsy or any other types of pathologies, because the choice of treatment could be based on or could be directed according to the prevalence of one or one type or more of these hypertonias, as we mentioned before. Spasticity could be easily treated relatively and as if compared with mixed hypertonias or dystonias. So we should evaluate the hypertonia very carefully, and we can measure the presence or justify the presence of other types of hypertonia at the same time. Actually, we have predictors of poor outcome. After that's what we can say after the selective rhizotomy. Not all children get benefit from. Why? Because there is a predictors like the diagnosis of type of CP hypertonia. Selective dorsal rhizotomy is working better for people with or for children with cerebral palsy spasticity rather than mixed forms of hypertonia. Actually, also the intellectual level and mental performance made the motor learning better in those children with good IQ level. Rhizotomy is done in the roots at 2 levels, either at the conus level through 1 or 2 levels laminotomies, or at the exit foramina through multi-level laminotomies. We can do the selective dorsal rhizotomy only in cases of spasticity, or combined anterior and posterior rhizotomy in cases of mixed hypertonia. Our goal is to improve the ambulatory function, improve the caregiving for those with severe form of disability, and prevent or control the development and the progress of severe forms of deformity like this boy. Technique of rhizotomy is done in prone position and under complete intraoperative neurophysiological monitoring and EMG recording, especially from sphincters. We adopt this technique in Ain Shams. We do multi-level laminoplastic flap and open the dura. I hope this video is running well. We open the dura, we identify the roots at the exit foramina, and we dissect the anterior root from the posterior root, and we made mapping by the stimulation and recording from the muscles, and we made an interpretation of the amplitude of response and pattern of response, and then we did the selective resection. Also, it's important to identify any responses from the pelvic floor muscles and anal sphincters. And this are example of recordings, and then we can coagulate and do the resections. And some cases for demonstrations. This is a 3-year-old girl with spastic diplegia. It's gross motor function level 3, walk with assistance. And this is 15 days just post-operative selective rhizotomy. We can compare the gait pattern in between 2 sides. In left side, she is 2 walker, and in the right side, she had good heel contact and good reciprocation pattern. This is just after 15 days of surgery. And this case is an 8-year-old girl with stiff knee gait pattern and equinus gait. And this is just 6 months, I think, after the surgery. She had good reciprocation, good knee flexion in mid-swing phase, and good heel contact in the ground, and more stable gait. And this is the curves for gait lab. Another boy. This boy has mixed form of hypertonia, spasticity, and dystonia. And this is after 18 months of surgery. He is now an independent ambulator. He's going intensive physical therapy, and he can move alone in good pattern with good balance in comparison to the preoperative condition. All these procedures does not require an orthopedic techniques after we are doing the rhizotomy. And this is another case. We can, for the sake of time, we can go for the next. This is an 5-year-old boy with more generalized form of dystonia affecting all body parts. He underwent combined rhizotomy, and this is 1 year post-operative. He can maintain sitting position, and we can, and this is after 1 year and a half, can sit more comfortably, and we can notice his upper limb also occur. This is known as the suprasegmental effect of rhizotomy, that the upper segments respond well to the also to rhizotomy. This couldn't be explained by the direct effect of rhizotomy, but maybe by the neuroplasticity and improving motor function in the brain. Also in adults, fortunately, this is a Yemeni patient with spinal cord injury, and this is he had very severe form of spastic dystonic hypertonia in both lower limbs. He couldn't do the gait patterns, and this is 3 months or 6 months after surgery. He can ambulate with assistance, with much less hypertonia and good independent walking. The beneficial long-term effect on gait parameters of these surgical techniques have a long-term very effectiveness on the gait parameters and pain reduction. Also the reduction of rate of acquired musculoskeletal deformity and later on surgery, orthopedic surgery, and improve of function, participation, and quality of life. And this systematic or meta-analysis study confirm what we said about the effectiveness of selective dorsal rhizotomy and physical therapy on long-term basis. And regarding the post-operative spine status after rhizotomy and after multi-level laminotomies, we didn't find any drawbacks of doing multi-level laminotomies. All cases had good fusion and good spine alignment after surgery, maybe up to 10 years after surgery. This paper compared between the multi-level laminoplastic techniques versus the single-level laminoplastic technique, and they didn't find any significant differences. But maybe the multi-level technique are superior in preserving the sphincters and identifying the sacral roots more better. Also, we can consider this anatomical and functional fact discovered by the Professor Golgi, which is the Golgi tendon organ, which is present, or the mechanoreceptor present in the myotendinous junction, that have an important role in controlling and in development of motor function, especially in children. This mechanoreceptor is very crucial, and any intervention regarding, or early intervention regarding tendon lengthening or tendon procedures before the age of 7 and development of gait patterns in the brain may affect it in very bad way. So we should limit or avoid any orthopedic interventions before the age of 7 and apply all neurosurgical techniques available. Regarding other technique, which is a selective peripheral neurotomy, it's introduced to literature by Lawrence in 1887. It was an obturator neurectomy for patients with a spinal cord injury. Then its techniques is developed to had better outcome, which is done by selective microsurgical techniques under stimulation and monitoring. And the most famous paper discussing the 10 years follow-up by Mark Sandu in 1988 and stated that there is long-term effect of selective peripheral neurotomy to maintain muscle function. Selective peripheral neurotomy is done at as distal as the motor nerve, when at the point of neuromuscular junction. We can sacrifice some fibers from the motor branch to the muscle, and it will be worked by the differential regeneration theory, where the motor fibers regenerate and the sensory fibers controlling the muscle spindle reflex regenerates in an disorganized way. This short video shows the technique for selective peripheral neurotomy for the soleal branch or the motor branch to soleus muscles, a branch from the tibial nerve. Here we can open the neural sheath, perineural sheath, and open the fascicles and select some fascicles according to the stimulation parameters. And this girl, 3 years old girl, underwent the selective peripheral neurotomy. This is, or tibial neurotomy. This is preoperative. She had talibus equinus gait. And this is postoperative. 2 or 3 months. She had good heel contact and improved level of ambulation. Hello?
Yes, Dr. Mujahed, por favor. Is he there? Dr. Mujahed, are you there? Okay. We need a moderator. Okay, maybe we need to ask a volunteer from the audience. Would anyone like to moderate this conference? I need a volunteer to moderate the conference because apparently no one's stepping up. Can you hear me okay, Walid?
Yes.
Yeah.
I think you finished the presentation, or I still have some slides.
Oh, I'm sorry. Go ahead.
Thank you, Dr. Professor Walid Abdel Ghany from Ain Shams University in Egypt for this nice presentation.
Okay, excuse me, sir. He hasn't finished his presentation. I'm sorry. I interrupted him. I'm sorry.
No, time
Okay.
is finished.
Can I continue, or?
Well, no. Do you mind if he finishes? I interrupted him. Go ahead,
more
Walid.
Okay, you can continue, Dr. Walid.
Okay.
Please finish. Please. I'm sorry. I interrupted.
Yeah. Dr. Walid.
Yes, I'm with you. This is another child with multifocal form of hypertonia affecting hamstrings, calf muscles, and adductors. In this case, we combine orthopedic surgery in the form of tendon lengthening with selective peripheral neurotomies, and we can see the result. Also, we can combine the more sophisticated orthopedic surgery with selective peripheral neurotomy. And it could be done also for adults. This woman had the post-spinal cord spasticity affecting the calf muscles, and she underwent the selective tibial neurotomy with more stable gait and much balance. Also, it could be applied to the upper limb in such girl with post-stroke left hemiparesis. We can do it in the upper limb with good relaxation and good motor function of the hand. In Ain Shams University, we adopt this algorithm to manage the pediatric hypertonia, depending on many scoring parameters, either physical, electrophysiological, or functional parameters, and we can place every type and degree of hypertonia in the right square. We have many techniques like the botulinum toxin injections, selective neurotomies, intrathecal baclofen, rhizotomies, and the orthopedic techniques. We can get this information. We had 2 published chapters in the literature about the spasticity and gait and the central and peripheral neurosurgical techniques for hypertonia. We can, in this book, Functional Neurosurgery and Neuromodulation, published by Professor Aslan and Kempershil. We can download the chapters and read every details. Based upon the best available evidence, standard care for children with cerebral palsy should include the green interventions. Both selective peripheral neurotomy and selective dorsal rhizotomy are effective on controlling spasticity, but in properly selected cases, results will be much better and long-standing. Combined rhizotomy may fill in the gap, part of the gap for cases with mixed form of hypertonia, and always multidisciplinary management is a must. Thank you for getting me in this conference, and we can join for questions if any. Thank you.
Dr. Walid, very much for this nice, interesting functional neurosurgical presentation. Now, question or comment from the audience, Dr. Abdel Ghany.
Any question?
Now, just to
thank you, Dr. Walid, for your comments. Thank you,
Thank you.
Dr. Walid, for your nice lecture. Just I would like to ask you, are you using percutaneous radio frequency for dorsal rhizotomy? Percutaneous, without laminectomy. It's
yes.
minimal invasive.
Yes, we use a percutaneous radio frequency ablation for the dorsal root entry zone and the root at the exit foramina, but it is not selective and could be done for those cases with severe form of hypertonia with no ambulation or no sexual function, or just to relieve the tone and pain. So it's not selective. But those with motor function and residual motor function and ambulatory level, we should go for the full exposure and applying the neurophysiological techniques and monitoring to select these fibers affecting the hypertonia with reserving the motor and sexual and sphincter function.
Other question, the hypertonia is temporary or it lasting forever? Hypotonia after procedures?
No, it's very it's temporary because it does not interrupt the motor fascicles, except in many in very selective cases and and few number of cases. So when we keep the motor fibers in the anterior root or the ventral root, we keep the motor function. We also, of course, we have some post-operative hypotonia from the manipulations of roots and cord, but actually it's improved within the few weeks or months after surgery with physical therapy.
Thank you very much.
Thank you.
Hello.
Hello.
I want to ask you, Dr. Abdel Ghany, in which cases you mix the peripheral neurotomy, for example, with orthopedic surgery? In which cases you mix the...
In which cases? Okay. When we find that there is severe form of focal hypertonia affecting certain group of muscles, and those muscles are going to anatomical shortening, we have both elements of joint range of motion limitation with hypertonia and with shortening. So we control the hypertonia with neurotomy and control the length with functional orthopedic procedures. So we have long-lasting effect on the muscle length and joint range of motion later on. In severe cases, in presence of contractures.
Thank you.
Okay.
Any other question or any comment? Thanks.
Thank
Now
you very much.
Thank you, Dr. Walid.
Thank you very much.
Welcome.
I'm happy
Hakim.
to share. Thank you. Goodbye.
Thanks.